Stay safe. So I'm going to talk about 2 case reports of unusual thoracic trauma, discuss the related pathophysiology, and discuss the diagnostic and therapeutic options. So our first case is a 21-year-old motorcycle collision. He arrived with his airway intact, no breath sounds on the left side, for which he had a left chest tube placed and a rush of air. His vitals were normal and stable initially. He had IVs placed, GCS was 15, and exposure was obtained. On secondary survey, he had road rash all over. He had bilateral upper extremity, obvious deformities, but with palpable pulses, and he had some pelvic tenderness. This is his initial chest x-ray in the resus bay. And this is his initial pelvic x-ray. And then he went for CAT scan. So I hope the image came out kind of clear quality. And remember, this case was a while ago, so this was pre-COVID. Certainly with the pulmonary contusions at this time, we'd be concerned for coronavirus, but this was way before that. One thing that's notable, which you all have probably seen, is that he has significant pneumopericardium, or air inside of his pericardium. And if you go back to that initial chest x-ray, it's subtle, but you can actually observe that there is some visible air on the x-ray you can observe. So the rest of the CT showed no intracranial hemorrhage. He did have a blunt carotid injury. He had a cervical spine fracture, multiple rib fractures and pulmonary contusions, and then pneumopericardium. He had a lot of orthopedic injuries, including bilateral radial ulna fractures, scapular fractures, and pelvic fractures. His pubic symphysis was widened to 1.8 centimeters, which wasn't that impressive on the pelvic x-ray. You can observe some mild widening there, but on the CAT scan, he actually had some arterial contrast extravasation posterior to the pubic symphysis with a hematoma. So after coming back from the CAT scan, knowing these findings, the patient became hypotensive. So I wanted to go around and see what people would do next with a hypotensive patient with these findings.
Dr. Alex, your comments, please.
Can you hear me?
Yes, sir.
Hello. So kind of going through the, ATLS. So basically, the lung is up, so he's not in tension anymore. He does have air in the pericardial sac, which can cause, tamponade. I don't know if that's decompressing into the left chest, if you have a lot of bubbling in the left chest tube. He can also be hypotensive because of the pelvic fracture. I think you said there was contrast extravasation. So I would start with a bolus of, can start with 500 cc normal saline to increase his preload. You can also definitely make sure you have blood available and switch to that with regards to the pelvic fracture. I would repeat his vital signs after that. And next would be definitely discussion with regards to maybe going to the operating room and maybe do a pericardial window to decompress that air from the pericardium. If let's say he's not bleeding that much from the pelvis, and this is what you're left with, like a tension pneumopericardium, that would have to be released somehow. These are my comments so far on this initial presentation.
Thank you, sir. In Miami, Dr. Gross, your comments, please.
Yeah, this gentleman, thinking of course, most likely patients who become hypotensive are due to hemorrhage. However, a couple other processes need to be excluded. There's tension pneumothorax, which with decompression of the chest could be is concerned. Typically think of tamponade due to blood, but looking at it seemed to be compressed or small. So I suspect there may be some tension there. I'd be interested to see what his neck veins are doing, to see if there would be any jugular venous distension. Looks with the CT scan, other sources of hemorrhage, chest, abdomen, pelvis, although he does have the blush, but not a lot amount of blood in the space of Retzius. His extremities don't seem to be a source of hemorrhage, and no report of external bleeding. So I'd be thinking about decompressing the pericardial space. Now, we're very fortunate this guy has a lot of space around the heart. So I would consider, although I've never done it before, try to release this pneumopericardium. Could use ultrasound guidance. We know it should be a safe procedure because there's plenty of space between the pericardial sac and the heart. Over.
Thank you, Dr. Gross. In Portland, Dr. Christine. I'm sorry. Go ahead, please.
I have one concern I thought about and I forgot to mention it. The airway. It's decelerating injury. Is his trachea? Trachea could be a concern. Where is this air coming from in the pericardium over there? So I would want to make sure his trachea is midline. There's no, sub-Q air around the neck, and definitely have that on my radar in the operating room to just make sure he doesn't have a tracheal injury.
Okay, thank you, Dr. Alex. Dr. Christine?
So this patient obviously has some chest trauma and pelvic injury, and I'm not sure whether he has any abdominal injury. So the first thing I would do probably would be a repeat fast. I'm sure that the doctors have done an initial fast. I would repeat it again to see the status of the pericardial space and make a note of it. And also I would repeat the fast in the abdomen to see if there is any obvious intra-abdominal, intraperitoneal bleed. And if it is nothing there and it is strictly in the pelvic cavity, I would definitely put a Foley catheter in to make sure that he does not have any injury to the bladder. And I would not force a Foley catheter. I would be very careful about it, just to make sure that the bladder is intact and there's no blood in the urine. So I think what I would do, I think I probably would do the same thing as my colleague from Miami. I think once you have identified the pneumopericardium, you need to release that air in case the patient becomes critically ill with low output failure. And it can be done because you have marked the pericardium and you know exactly how much air you have, and using a needle technique, you can allow the air to escape quite readily without injuring the right and left ventricle. So the next thing would be, after you have done that and the patient has not stabilized, and then you need to go to stop the bleed in the pubic symphysis, in the pelvic area. There are two ways of addressing this. You can go for a Ribova and then IR to embolize the area. If you don't have that facility, open the pelvic cavity extraperitoneal and then pat the pelvic cavity and see if you can get hemostasis by that means. Thank you.
Thank you, Dr. Kasim. Uruguay, Dr. Mineri, your comments, please.
Yes, I'm sorry. I think this man is like bleeding from all the fractures it has. It's pelvis, ribs, and arms, bones. And I think I put volume blood and see what happens. And maybe release the tamponade. I don't know if he has clear signs of tamponade.
Thank you, Dr. Mineri. Dr. Calais, Sao Paulo, your comments, sir.
Yes, I agree with the comments, but I think this patient is not intubated. Yes or not?
Not at this time.
Not at this time. The great problem in this moment is to have a patient unstable. This patient may be a pericardial air in the pericardium. So you have a link from the pleura or for the trachea to the pericardium. If the patient is not intubated, no problem. If you put a tube, endotracheal tube in this situation, you can aggravate the pericardium and maybe tamponate this patient quickly. So it's very important to know. It's very difficult to diagnose this, but I think it's very important to know that if you put this patient in a positive pressure, RA positive pressure, maybe this compensates the cardiac tamponate by air. So in this moment, I agree. We start with the procedure with punction of the pericardium, because you need to tamponate, you need to intubate the patients to control the patient. The patients can be the surrounds of the hypotensive because the cardiac problem, because the compression of the pericardium by the air, compress the heart by the air in the pericardium, and you have a problem in the pelvis. It's very clear that the patients have a hematoma in the pelvis, so you can go to control the hemorrhage in this area. So to control the hemorrhage in this area, you need to can go to arteriography, it can be put embolization if the patient, or you can put a revolver. It's not very safe at this moment. And I agree that patients go to a tamponate, extraperitoneal packing of the pelvis. So I put the patients to OR and tamponate the pelvis. Then I go back. I agree that patients need to start the protocol of a massive transfusion protocol, maybe start or maybe become used in this situation. So first, I believe that patients need to decompress the air in the pericardium. Then the patients can be intubated. Then the patients can see what will happen. After you can see the trachea by bronchoscopy or not during the surgery. So that's the way that I go.
Thank you, Dr. Calais. Dr. Grigsby, Norfolk, your comments, sir?
Yeah, I'm kind of agreeing with everyone so far. I think this patient needs pelvic packing for this pelvis bleeder, as well as we need to drain what's going on in the heart. I've never really experienced this before, but I think I would start with doing pericardiocentesis and just getting the heart drained for time being. And because it's not fluid, I'm not concerned for injury to the heart, yielding blood, but just kind of putting pressure on it. I think that's where I'd start. I'd get the patient to the OR, get a drain in there, and then explore the heart if needed, and then get the pelvis packed. If the patient's abdomen does not need to be open, then we can try to avoid that. And we can consider things like peritoneal lavage if he's still hypotensive, but don't have a strong suspicion of intra-abdominal bleeding.
Thank you, Dr. Grigsby. Dr. Varon, have you observed enough to comment yet, or would you like to wait? Okay, same question for Dr. Frisbee. Good morning, sir. Have you observed enough to comment, or would you like to wait? You're muted, sir. You're muted, Dr. Frisbee.
All right, can you hear me now? Good.
Yeah.
Well, the only thing I can say is he's really broken up. And I think the comment that someone made with regard to his bleeding from every fracture is probably true. I would start his massive transfusion protocol and get that air out of that pericardium, because if you try to intubate him, he's gonna dive on you. I don't have a problem with extraperitoneal packing of the pelvis at all. I think that's going in the right direction, but I think he's just bleeding from everywhere now. And I'd get that air out of that pericardium with whatever method you want to use. Whether you want to put a window in there or whether you want to put a needle in it, that's fine with me. But I don't think you can get him intubated until you do that. That's all I've got.
Okay, thank you, Dr. Frisbee. Anyone else like to comment before we return to our presenter?
Sure. Oh, sorry.
Oh. Go ahead.
Sorry, who's next? Okay, it's Dr. Calderon from Peru.
Hi,
Yes,
Dr. Calderon. Hello.
Yes, good morning. I'm sorry I missed the initial part of the presentation. Yes, according to this injury pattern you're presenting right now, I don't see an obvious bleeding in the images. So I would start, once again, I was also thinking about a cardiac tamponade, but I would repeat the fast just to see some more fluid coming out in the abdomen or the pericardium. I would also tap the pericardium, but I will also place a left chest tube. Even if you have a small left pneumothorax, I must anticipate that this victim will need an airway. So I would go ahead placing the left chest tube. And there are some surgeons that still do the DPL. I would do a DPL to see if some blood is coming out from the abdomen, and even if the DPL is negative, maybe we will take the patient to the OR for a laparotomy and to do the pelvic packing. What else? I guess he already is in massive transfusion protocol. That's it.
All right. Thank you,
Gary,
sir.
was there a question about the airway, I understand?
Not quite sure.
Okay, I think somebody asked if we should, I just had to step out for a second, if you should secure the airway first or regarding the massive transfusion protocol. My answer would be I would secure the airway early, but I would be very careful in the kind of volumes that you're giving to make sure that the patient doesn't go further into hypotensive because of that, because of pneumopericardium. So I would secure the airway, probably at the same time you're putting the chest tube, but keep the volumes really low so you don't make the patient worse from the hypotension standpoint.
All right. Thank you, Dr. Varon.
Gary,
Gary,
we have a new, sorry.
No, go ahead, please. Yeah.
We have a new participant. His name is Dr. Talat Chuktai. He's a very famous surgeon, and I'd like to hear from him.
Okay. Dr.
Hi,
Chuktai, go ahead, please.
Yeah, hi. That's a nice introduction. Thank you very much. So everybody, I agree with everybody's comments, of course, about the pelvis and about the airway and the chest tube. One thing I keep in mind here is that there's a pericardial rupture since there's air there. And so that means two things. One, there's significant force. And so maybe cardiac confusion is one explanation for hypotension. And the other thing is, the heart may be torsing. If there's a significant pericardial rupture, there may be some cardiac torsion, which might be, catch on the x-ray right now, but maybe happening intermittently. I've seen a case like that where the next x-ray shows the heart flipped into the right chest when there was some unexplained hypotension in this type of polytrauma case. So I'd keep that in mind as well. Keeping in mind a thoracoscope might be something interesting to evacuate the air as well as look at to see what's happening.
Thank you, Dr. Chuktai. Thank you for bringing that to my attention, Dr. Singh. Did we miss anyone before we proceed? Okay, Dr. Shnaydman.
All right. So just to address a couple of things that were mentioned, the FAST exam initially was negative. There was some difficulty visualizing the pericardial FAST, which in hindsight was due to the error on the heart. And the CT scan showed shockingly no intra-abdominal injuries besides the pelvic bleeding. So when he returned from CT, he was hypotensive. He had his lines placed, MTP was started. We placed a Reboa catheter prophylactically into the femoral artery without inflating it, just to have it in place. And then we placed a pelvic binder to reapproximate the pubic symphysis. And then he was taken straight away to the OR. So in the OR, a subxiphoid window was performed. This picture is not from that particular case, but a rush of air was noted. And then immediately he had an improvement in his hemodynamics. We performed preperitoneal packing. And during all of this, his hemodynamics continued to worsen. So we inflated that Reboa catheter that was already placed, and we called IR intraoperatively so that they can do a pelvic angiogram and possible embolization. However, they didn't see any active foci of bleeding on their angiogram. So now at this point, he's more or less stable after receiving quite a lot of blood products. We have the pericardial window done. We placed some pericardial drains through that. And now we have to evaluate the source of where did this pneumopericardium come from. So we performed an endoscopy just to rule out a blunt esophageal injury, which was normal. And then we performed a bronchoscopy. And unfortunately, I don't have a picture of it, but on the left side, there was a visible injury in the left-sided bronchus where you can see the pericardial fat through the bronchoscope. So I wanted to stop here and see what everyone would do with these findings. And now with the patient being relatively more stable than he was.
Yes, sir. Dr. Frisbee, your comment, sir?
Well, looks like you found it. It would depend on the condition of the patient as to whether or not you wanted to tackle that, where the actual intrusion from the, or extrusion from the bronchus is. If it's up high, I might want to see if I couldn't do something about it, but if it gets really low, I might just close it off.
Yeah, it was pretty low, like a tertiary bronchus on the left side.
Oh, take the TA25 and come across there. Stop that bronchus from pouring out. That's what I would do.
Thank you, Dr. Frisbee. Norfolk, Dr. Grigsby, your comment, sir?
Yeah, I think I agree with you. Can go across that section of the lung pretty easily and take care of things.
Thanks, Dr. Grigsby. And Peru, Dr. Calderon?
Yes. I already have a left chest tube, and I will do a thoracoscopy, try to close that injury.
Okay, thank you, Calderon. Dr. Calderon, forgive me. Portland, Dr. Kasim, your comment, sir?
Did the chest tube that you placed there, did it bubble?
There was no active bubbling coming from there.
Okay, that's kind of strange. So I think Dr. Frisbee is right. I think I would go after it with the TA, whatever you have, and take care of it. Thank you.
Thank you, Dr. Kasim. Dr. Choktai, your comments, please.
Yes, hi. Yeah, so I overall agree, you know, double lumen tube if possible, and lung resection, and then cover the whatever you have with some sort of vascularized tissue. As well, during your thoracoscopy, if you can do this thoracoscopically, take a look at the pericardium to see how big a tear there is. Might be just small, but in case it's something you need to do something about.
Thank you, Dr. Choktai. Ryder, Dr. Gross, your comment, sir?
A question, Dr. Shnaydman. What's the patient's clinical status at this point, hemodynamics and transfusion requirements? Over.
So he required several rounds of MTP, and after the IR angiogram was performed, there was no bleeding done. The Reboa was taken down, and he was stable, but he did receive a lot of blood product.
Okay, and so the chest tube that's in place now has not been bubbling?
Yeah, the left chest tube is in place, and the pericardial drains are in place, and it seems that everything's working, and the patients responded well hemodynamically.
You know, obviously there's a significant rent in that tertiary left-sided bronchus. However, I don't know that I'm necessarily forced at this point, provided that we have adequate decompression of the pleural space. I'd be inclined just to ensure that he's on watch your tidal volumes and pressures very closely, but I wouldn't necessarily feel compelled to proceed with resection at this point. Over.
Thank you, Dr. Gross. In Sao Paulo, Dr. Fillet?
At the moment, the patient may be stable. So you can wait. You can put a pericardial tub and wait, because the flap may be small and they can be closed spontaneously if you cannot go to device this. Or you can go to make a thoracoscopy or maybe a thoracotomy and treat the fistula. So sometimes you can use through the bronchoscopy to close the fistula too. You can put glue in the fistula on this area and close this fistula. Maybe one procedure is possible, or put a stent in this bronchiole and close the fistula and then wait the patient. So we have sometimes some procedures can do by bronchoscopy. You can put through a stent through the bronchoscopy to close the pericardial flap, the bronchus fistula. You can try to put some glutes in the fistula, can be close it too. you can only wait, can put a drain in the pericardium and wait, and you can go to a thoracoscopy or thoracotomy and treat the fistula. I believe if the fistula is too small, you can treat by bronchoscopy or by wait or conservative treatment. So that's the way I go to.
Thank you, Dr. Calais. Back to Ryder for Dr. Varon, please.
I agree with what Dr. Gross says. From the standpoint, if the patient is stable, you don't have bubbling, I mean, you don't have a big bronchopleural fistula. From all standpoints, I don't think we need to rush to fix that. We may end up doing more harm if this is just a small seal on its own. So I would watch the patient for a bit longer before. I'm not a surgeon, but I don't see the rush to fix that if the patient has other issues like the pelvis or other issues that need to be addressed.
Thank you very much, Dr. Varon. Up Dover to Dr. Alex. Your comment, sir?
It makes sense that the left chest tube wasn't bubbling because there was a tear in the bronchus and all the air was going in the pericardium. With regards to addressing that, and seems to be somewhat distal, depending on the size, which only you can assess when you're in the operating room, based on how the patient is doing. The options are as were discussed. I really like the one with the stent, which may give may avoid the thoracotomy and working in a difficult spot over there. With regards to, you said multiple rounds of MTP, I wonder where did that blood go? Is there something in the retroperitoneum that is not picked up yet or evolving? And back to the airway again. The other option is to maybe slide the ET tube, do like right main stem, and use one lung until if it's a small tear on the left side, allow that to heal. And keep the patient intubated. But I'll definitely re-image and see what's going on, where all these rounds of MTP went. Maybe something going on in the retroperitoneum. And I would do an echo to look at the heart. If it was a blunt force like that, definitely may have caused some problems, maybe valvular injury or some contusion that would suggest, or that may explain your hypotension on the patient if he still has it.
Thank you very much, Dr. Alex. Uruguay, Dr. Mineri?
Yes, I think I didn't rush into surgery. Maybe the patient is stable with the drains in the thorax and the pericardium. Maybe he can wait, and maybe this fistula closed by itself. Maybe it doesn't work. Maybe we have a mini invasive like bronchoscopy to put a stent, or maybe we can fix the problem.
Thank you, sir. Did I miss anyone who would like to comment before we continue? Back to you, Dr. Shnaydman.
All right, so some excellent points raised. We definitely agree that the patient was getting massive transfusions, and at this point he was stabilized. The pericardium was drained, so we opted to leave him intubated and bring him to the ICU with the chest tubes and pericardial tubes all on suction. However, several hours later, the patient now became hemodynamically unstable again, showing tamponade physiology. Just in the interest of time, I'm just going to keep going. So we took him to the operating room, and we did a median sternotomy, and we found that he had an injury in the segmental branch of the lingula. He had about a 2 to 3 centimeter rent in his pericardium, and when we were dissecting that, we found the injury to the tertiary bronchus was about 6 millimeters. So we performed a repair with a pleural patch. He had some new chest tubes placed and pericardial drains. And then he continued the rest of his hospital course. So he had that carotid injury I mentioned earlier, which he had aspirin for. He eventually went to the operating room with orthopedics for all of his extremity fractures. One chest tube was removed on day 3. He was extubated on day 4. And he had a repeat CAT scan on day 6 because he started to have leukocytosis and fevers. And we were worried he had an undrained collection or infection. But it looked like it was just pericarditis at that point. So he was started on NSAIDs. And subsequently his leukocytosis and fevers resolved. And the patient underwent a repeat CT scan to evaluate the blunt carotid injury. There was no progression, and we only did that because it was a fairly high-grade injury. And he was eventually discharged home on postoperative day 18. So unless anyone has any comments, I'm just going to proceed to the next case.
Sorry, just one question about the pericardium. Sorry, you said you repaired the bronchus and covered it with pleura.
Yeah.
What did you do with the defect in the pericardium?
So we left the pericardium open and left it drained.
Okay.
Okay, if no additional comments, Dr. Shnaydman, were you going to present your next one?
Yeah. So 28-year-old male, ATV collision, airway was intact. He had bilateral breath sounds. His vitals were normal and stable. His secondary survey showed some right chest tenderness, and the FAST was negative, but again, it was difficult to visualize the pericardium. We got a chest x-ray and a pelvic x-ray, which demonstrated a right-sided pneumothorax and a chest tube was placed. So you can see a thin stripe there. Chest tube was placed. And same thing, very subtle, but you can see a thin stripe of air surrounding the pericardium. So he was hemodynamically stable, so he went for CT scan. He had extensive pneumomediastinum and pneumopericardium and sub-Q emphysema, multiple rib fractures and right lower lobe pulmonary contusions, a clavicle fracture, and a large liver laceration, but without any contrast extravasation. So here are some cuts from his CAT scan. You can see a lot of subcutaneous emphysema, and you can see the pneumopericardium is very extensive. And then as the last patient, as soon as we got back from CT, the patient became hypotensive again. And he started to show us tension physiology and was subsequently taken straight to the OR. So I wanted to talk a little bit about this pneumopericardium, which I think is fairly rare. And as most rare things, they come in groups. So both these patients came about a week apart. So it's quite rare, but you have to be vigilant because certain series find up to 60% mortality. Part of that is because unless you obtain CT, the findings are quite subtle. And in trauma, we always think people are bleeding when they're hypotensive. So you have to keep an open mind and consider this as part of your differential. Charles Macklin in 1939 published this paper, which was the first instance I could find describing pneumopericardium. And the question is, where does the air come from? So he actually found that the air travels along the pulmonary vasculature into the mediastinum and into the pericardium. At that area, there is no continuity of the visceral and parietal pleura, and so there's actually a direct connection into the pericardium. And interestingly, in his paper, he was trying to figure out a way to prove this because every time he did experiments where he injected a balloon and inflated a bronchiole under pressure to pop it, as soon as they did the dissection, the air escaped and they weren't able to show it. So he found that performing immediate fixation of the tissues with formalin and then processing it that way, he was able to demonstrate there truly is air. And you can see these cuts where there, in the bottom image, there's an artery, and the ASA is the air surrounding the artery that just dissects along that vessel. So you can have, concomitant pleural and pericardial tear. You can have a congenital connection or direct trauma, like if you have a GSW or stabbing where there's a direct connection between the two structures. And as I mentioned, on the X-ray, it shows up as just a silhouette around the heart. And this X-ray is much more obvious, but as you can see from the other cases, it's very difficult to see unless you are looking for it. On the CT, it's a lot more obvious. And then the signs of tension pneumopericardium are the same as for regular cardiac tamponade, so paradoxical pulse, tachycardia, increasing CVP, jugular venous distension, muffled heart sounds. And most of the time, these patients have a concomitant pneumothorax and pneumomediastinum. So usually they require chest tubes and endoscopy and bronchoscopy. And even if these patients are stable, they should be in an ICU for continuous monitoring because they're at high risk of arrhythmias. The important thing, which I think Dr. Clay stressed, is that it's usually self-limiting, but the most dangerous thing for these patients is the positive pressure ventilation, because that's what can produce a tension pneumopericardium. And just as with patients who have tamponade, these patients need to be prepped and draped, and everyone should be ready because as soon as that positive pressure is applied, you can turn that into a life-threatening, immediately dangerous situation. So this patient, we took him to the operating room, performed a subxiphoid pericardial window. There was a rush of air, a 28 French chest tube was placed into the pericardium, and he had additional chest tubes placed. This patient's endoscopy and bronchoscopy was normal. Here's his postoperative photo and his postoperative x-ray. So you can see the pericardial drain and the chest tubes. On day 3, he had ST elevations on his EKG, and his troponin was 11. Not 0.11, but 11. So I wanted to ask what everyone would do at this stage.
Over, Dr. Alex, your comment, sir.
So The troponin 11, I assume maybe no more kidney function. How is the patient doing clinically? You know, does he have any new chest pain? Are his vital signs otherwise okay?
I believe at this point he's intubated, so you can't tell us if he's having chest pain. And his vital signs were okay. And as you mentioned, the renal function was normal.
I mean, I would definitely trend this, and I would definitely, you know, get cardiology on board. You know, he needs to be ruled out for you know, coronary event, which may occur due to the impact, the small tear in the coronary, and then kind of slowly built up into some form of occlusion. That's what I would do for this at this point.
Thank you, Dr. Alex. Sao Paulo, Dr. Tele, your comments, please.
Okay, in these situations, I believe the patients have a contusion of the chest, so they may have a heart contusion. So the patients may need to see the heart. So in this situation, sometimes it's very interesting to make an echocardiogram and esophageal echocardiogram to see the heart and the regions. I agree with the problem that sometimes patients may be a dissection of the coronary artery by the trauma and may become a ischemia event in this situation. Or it becomes to have a plaque, arteriole and maybe a thrombosis of this arteriole. And may become this event. So in these situations, I need to see the heart. Usually, maybe very echo endoscopy, a Doppler, ultrasound Doppler from the esophagus to the heart to see the heart, and maybe sometimes I go to call the cardiologist to see, and sometimes these patients need angiocoronariography. That's
Thank
it.
you. Okay, thank you, Dr. Tele. Dr. Chotai, your comments, sir?
Yes, another interesting case. So I agree with echo, look for regional wall motion abnormalities. I don't know if it's possible to look at the CT scan that he had with contrast and see if there's any way to look at the coronaries, but if you see anything big. But I guess, you know, he needs some sort of investigation to see, is it a flap, is it previous disease? And the next decision is going to have to be, I guess, how do you anticoagulate him, both antiplatelet wise and otherwise? Is he safe to be anticoagulated?
Thank you very much, sir. Down to Miami, Dr. Varon, your comments, please.
Yeah, question. Just remind me, how old is this patient?
He's in his 20s.
Okay, so the reason, just to confirm that, I think this patient does not have an MI. I think this patient has pericarditis. If you notice, the ST segment elevation is in multiple leads. It's only not on the anterior wall. So he needs some NSAIDs. And I've seen this before. When you cut into the pericardium and play with the heart, you can get some troponins. I don't think this 20-year-old is having an acute heart attack. I think he's having pericarditis after you tickle his heart and open his pericardium.
Thank you very much, Dr. Varon. Uruguay, Dr. Maneri, your comments, sir?
No, I can't really say much, but it's just learning.
Very good, thank you. In Peru, Dr. Calderon, your comments, please.
Yes, I am not a cardiologist, but I was taking a look at the EKG. It does have the ST elevations diffusely, and it does happen in the pericarditis. And also in the cardiac contusions, we do have elevations in the troponins and the CPKs. I think it's just a cardiac contusion, but it's very wise to call the cardiologist, to have an echo, to have the trends in the troponins, and just to observe this patient, especially in the cardiac rhythm. He's 28 years old, so it's unlikely that he have previous coronary artery disease. I think it's only a contusion.
Thank you, sir. Portland, Dr. Kassim, your comments, please.
I think it is possible this patient, during the blunt trauma to his chest, he may have had some injury to one of the coronary arteries, and then several days later, he may have developed a thrombus within it. But more than likely, from the EKG, I agree with Dr. Warren that this looks like pericarditis. So even though the troponin is markedly elevated, I wouldn't jump into anything other than giving the patient anti-inflammatory and watchful waiting at this moment. He's young, he should be able to overcome this pretty rapidly. Thank you.
Thank you, Dr. Kasim. Dr. Frisbee, your input, please.
Yeah, you know, I'm not stepping in this deep water. This is this is way beyond my pay grade. I'd get the cardiologist, and maybe Dr. Barron can pull my behind out of this, because I'm not going there. This is not my province, and I'll need a cardiologist or an anesthesiologist to tell me what's going on. It's obvious cardiac injury, but the type and the variety, I'll need somebody a lot smarter than me to tell me. That's all.
Thank you, Dr. Frisbee. You're a very modest man. Back to Miami. Dr. Gross?
Great, thank you. I'd like to review the TEE very closely just to ensure there is good cardiac squeeze, and we should be able to get a good visualization of the heart from that. But excluding any evidence of cardiac contractility problems, I'd be more inclined to think of the pericarditis. Over.
Thank you, Dr. Gross. Do we have any additional comments before we continue? Okay, Dr. Shnaydman?
So I think all of the comments are very valid. Certainly we considered pericarditis because many of these patients do get pericarditis, but we were concerned about the troponin of 11, and we were concerned that he may have developed an intimal flap and perhaps on day 3 clotted it off. So as Dr. Frisbee mentioned, we did get the cardiologist involved, and they actually took him for a cardiac cath. So his cardiac cath was normal, patent vessels, and we thought he just had a myocardial contusion as well as pericarditis, and he was started on NSAIDs and colchicine. And then the rest of his hospital course was relatively uneventful. The tubes were removed. He developed a pneumonia, was extubated, and discharged home. So I just thought these would be 2 good cases to discuss because they're something we don't see very often and something I think we need to keep somewhere way in the back of our mind.
Thank you. Great cases.
Thank you for your presentation, Dr. Shnaydman. Dr. Marttos, would you like to comment? Close the session.
Yeah, great presentation. I knew the case. Very nice to see our fellows presenting these cases, and I hope next week we're going to have another good case from Campinas. This meeting has been going on for 10 years, and it's always a pleasure to see our fellows presenting, and then the people moving on, and then having join us from the place where they work. And also very nice to see all the other sites around the globe connecting to us. Thank you very much. I hope this meeting continues for another 10 years. Thank you.
Thank you. So everyone, for those who need it, allow me to draw your attention to the screen here where the CME code is. And please watch your emails for updates coming from Valeria about our future sessions. Stay safe. Thank you for joining again. Take good care of yourselves.
Thank you. Very nice case. Thank you very much.
Thank you. Thanks.
Very nicely presented. Very good
Thank
case.
you.
I was going to ask one question, if I may, but I guess it's too late.
No,
Go ahead.
My question was, so how do you recommend, in this situation, patient has, right chest tube, left chest tube, pericardial drain. How do you decide, the sequence, what comes out first? I mean, not necessarily for the chest tubes, but like the timing when you're going to take the pericardial drain out. You're going to do like a sort of water seal, kind of clamp it and scan the chest to decide when it's time to come out. If you can comment on your decision making with regards to that.
Great question. So we absolutely had a lot of paranoia about taking it out too early, given that both of these patients developed tamponade physiology from the leak. So I believe we took the chest tubes out first, and both of these pericardial drains weren't draining much fluid, so it wasn't a question of the volume. I think they were both removed after about a week. And of course, we made sure there was no bubbling before we would take them out.
Okay.
But certainly,
Yeah, thank you. If
the patients would stay in the ICU while those drains are in, even if everything else is well, because of the risk of arrhythmias, just having the tube in and then observing them in the ICU at least one additional day after the tube comes out.
Yeah, thank you, Ilya. If I may, I'm Gabriel Ruiz. I was the actual attending on this case, and Ilya is right. On the first case, Ilya is right. The presence of air leaking was key. The absence of air leaking was key. So we kept on looking for an air leak, with a lot of paranoia. And until we were sure that we couldn't reproduce an air leak into the tube, we didn't take it out. But it took us almost a week to get it out. It was scary.
Yeah. Good case, though. Really good.
Great case. Thank you.
All right. Thank you, everybody.
Thank you, everyone, for joining. Stay safe.